we've been interested for a long time in how the ischemic myocardium behaves when we study it by Strainechocardiography, and we have several experimental studies and clinical studies which I would like to share with you. This is the outline of my study, of my presentation. First, I will define acute coronary syndrome and non-ST elevation myocardial infarction. Then I will explain how the method 2D wall motion tracking works, and then I will discuss the experimental and clinical experiences in the use of 2D wall motion tracking in the diagnostics of ACS and NSTEMI. And then I will wrap up with my conclusion. Coronary artery disease is the leading cause of morbidity and mortality worldwide. Coronary angiography is the gold standard for the identification of CAD, and 2/3 lead to intervention in patients with non-ST elevation acute coronary syndrome. Acute coronary syndrome comprises ST elevation myocardial infarction and non-ST elevation myocardial infarction. STEMI patients are easy to identify. They have chest pain. On the ECG, we see, as you all know, ST elevation, and when we see this, we send the patients directly to acute revascularization therapy. On the other hand, non-ST elevation acute coronary syndrome is a more heterogeneous group and comprises unstable angina pectoris and non-ST elevation myocardial infarction. These patients have chest pain. On the ECG, we might see ST depression, T inversion, or no changes at all. In case of normal cardiac markers, the diagnosis is UAP. In case of elevated cardiac markers, the diagnosis is NSTEMI. When we send these patients to angiography, we might find no significant coronary artery disease, significant coronary artery disease, or occlusion. Importantly, about 30% of NSTEMI patients have coronary artery occlusion, and they share the same pathophysiology and the same prognosis as STEMI patients. So these patients should be identified and sent to acute revascularization therapy in order to save myocardium. Yes, so how can we assess myocardial function? We can use 2D wall motion tracking. This will be a repetition after Dr. Pandian. The method uses 2D echo images where these acoustic markers, also called as speckles, are identified by the software, and then they are followed, they are tracked throughout the cardiac cycle from frame to frame. This is, and when we are following the speckles throughout the cardiac cycle, we can determine regional function, regional deformation, or strain. Here we will, this is a schematic presentation of the left ventricle. We will focus on the mid-septal and the mid-lateral segments. During systole, there is a shortening, and we get also strain curves where we can follow deformation throughout the cardiac cycle. Please note that maximum myocardial shortening usually occurs at the end of systole at aortic valve closure. Since we talk about shortening, the sign of strain is negative, and normal longitudinal strain is around -20%. So we can assess strain in the apical long axis views. As I just told you, longitudinal shortening, we have negative strain curves, and transverse thickening, then we have positive strain curves. We can also assess strain in the short axis, radial thickening, again positive strain curves, and circumferential shortening, negative strain curves. We can assess myocardial ischemia by Strainechocardiography. It's been shown earlier in experimental study. This is a study from our lab from 2005. Where we have used Strainechocardiography and sonomicrometry. This method uses crystals which are implanted in the myocardium, and then by sonomicrometry we can follow the crystals and see if there is shortening, thickening, or whatever motion there is in the myocardium. In the first experiment, the LAD artery was occluded for 15 minutes, and as you can see, instead of shortening at baseline, there is a lengthening of myocardium during ischemia. When we reperfuse the tissue, there is a recovery of function, and after 3 hours, there is an even increased recovery. However, the tissue never recovers completely. On the other hand, when we occlude the LAD artery for 4 hours, there is no recovery of function. So this method seems to work. This is a clinical study from our laboratorium where we looked at 40 STEMI patients treated with PCI, and then after 9 months, late enhancement MRI was performed to determine infarct size, and also an echocardiography was performed to study strain. The patients were grouped into small, medium, and large infarction according to the MRI study. Here to the upper left panel, we see a patient with medium-sized infarction, and below we see corresponding strain curves. We have radial strain in blue, longitudinal strain in red, and circumferential strain in black. And to the right, we have a patient with large infarction, and as you can see, global strain values are decreased in all directions. When we look at the table, we can see that longitudinal and circumferential strain by speckle tracking and strain rate and strain by tissue Doppler imaging could not only separate large from medium and small sized infarction, but also between small and medium sized infarction. So it is a sensitive method, more sensitive than traditional methods like ejection fraction and wall motion score index. In the next study, we looked at 126 NSTEMI patients, within 48 hours of symptom onset. And this is an example of a patient with chest pain on the ECG. There is no STT changes that would make us send this patient to acute revascularization therapy. Nevertheless, when the patient got to angiography, we found a large intermediate artery which was occluded. After PCI, we see the result. An echocardiography was performed right before angiography, and this is a bullseye plot of strain values demonstrating functional risk area of 9 adjacent LV segments with systolic function by strain worse or equal to minus 14%. To the right, we see an ROC curve analysis set to identify patients with coronary artery occlusion, and at a cutoff value of 4 or more segments, functional risk area could identify patients with occlusion with a sensitivity of 85% and a sensitivity of 70%. And it was better again than the traditional ejection fraction, wall motion score index, and even global strain. Gren et al. Took the same idea one step further, and they looked at 85 patients with suspected NST-ACS. Immediately in the ER, when they entered the ER, they did an echocardiography, and they calculated territorial, longitudinal, and circumferential strain according to the perfusion territories of the 3 major coronary arteries. Again, to the right, we have a ROC curve analysis set to identify patients with coronary artery occlusion. And in this study, territorial circumferential strain had an impressive sensitivity and specificity around 90%, while the other parameters, the traditional parameters, were not that useful. This is still the same study. There was it's a very important figure. An echocardiography was performed also after 3 months, and here only patients with NSTEMI and coronary artery occlusion were included. The patients were grouped into 2. Those patients who were lucky enough to get to the revascularization therapy within 12 hours improved myocardial function at 3 months, while those who had to wait longer, according to guidelines, they did not improve myocardial function in the ischemic area. So again, these patients should be identified early and sent to revascularization therapy in order to save myocardium. In the study, we looked at 77 patients with suspected NSTEMI within 48 hours, again, of symptom onset, and we assessed layer-specific deformation. And the background for this study is that the LV wall is a three-dimensional continuum of myocardial fibers with an inner right-handed helix, a middle circular layer, and an outer left-handed helix. These layers cannot be separated anatomically, but it's known from earlier study that the endocardial layer is most susceptible to ischemic injury and undergoes greatest deformation during systole in a healthy heart, including thickening and shortening. Before we go on with the study, it's been shown earlier that there is a gradient from endo to epicardium with greatest deformation at the endocardium and lowest deformation at the epicardium. Later, it's been also shown that there's a gradient from base to apex with the greatest deformation at the apex. But back to our study, this is an NSTEMI patient with left circumflex artery occlusion. This is a four-chamber view of the heart. Our region of interest is the left ventricular endocardium. And as you can see, the segments supplied by the left circumflex artery have reduced color-coded deformation, while the other segments have normal color-coded deformation. When we look at the corresponding strain curves, we can see that there is reduced maximum myocardial shortening in these two segments. And we can also see post-systolic shortening in one of the segments. These are the results. So we had three groups of patients: patients with no significant coronary artery stenosis, patients with significant coronary artery stenosis, and patients with occlusion. If we just focus on our best parameter, which was territorial longitudinal strain, and when we look at the results horizontally, then you can see there is a decrease in deformation as we move from left to right in all layers. Importantly, the greatest reduction in function is in the endocardial layer. When we look at the results vertically, we can see this endo to epicardial gradient, which have been shown earlier, and the table below shows the absolute difference between endo and epicardial deformation. As we move towards the right, this gradient decreases, and it's even less in patients with coronary artery occlusion. There was no significant difference in ejection fraction between the groups. Wall motion score index was worst in patients with occlusion. This is an ROC curve analysis set to identify patients with significant coronary artery disease. And here, endo and mid-myocardial TLS, territorial longitudinal strain, were the best parameters to identify patients with significant coronary artery disease. These parameters were better than epicardial strain, but also better than ejection fraction and wall motion score index. Unfortunately, our software didn't allow the analysis of transmural or standard strain, so we cannot say if it's better or the same as transmural strain. But there is a study from Israel, an experimental study, which might give some answers. In the study, infarction were induced in rats by occluding the LAD artery. One group of rats were sacrificed after 24 months, and the rest after 2 weeks, and the histopathological study was performed to analyze transmurality. There was also a layer-specific strain and transmural strain analysis performed before the animals were sacrificed. When we look at the ROC curve analysis, which were set to identify rats with transmural infarction, we can see that at 24 hours, endo and mid-myocardial strain was significantly better, the blue and the green lines, than transmural strain, the black lines, to identify patients with transmural infarction. However, after 2 weeks, this difference has disappeared. And it was speculated in that the reason for this is that there is a collagen deposition and fibrosis after 2 weeks make it making it impossible to separate the function of the different layers due to very strong tethering. Nevertheless, there are many clinical studies claiming that it's possible to differentiate between transmural and subendocardial infarction using layer-specific deformation in patients with chronic ischemic heart disease. All these studies are done in chronic ischemic heart disease and not acute settings. The last study, an experimental study from Bergen in pigs, they may be more similar to us. They induced graded left anterior descending artery stenosis from 15% up to 60%, and then they analyzed 1- and 3-layer strains by speckle tracking, echocardiography, and tissue Doppler imaging. They did it longitudinally, circumferentially, radially. They assessed rotation and torsion. And they concluded that 1- and 3-layer strains, both by speckle tracking and tissue Doppler imaging, started to decline simultaneously. So endocardial strain didn't start to decline before the standard transmural strain. In addition, they found that peak mean rotation was not reduced until severe stenosis, and torsion remained unaffected by ischemia. So, in conclusions, assessment of myocardial deformation by strain echocardiographic techniques may help to identify patients with coronary artery occlusion and significant CAD in acute settings. It is still unclear if layer-specific strain analysis is better than standard strain analysis to detect acute coronary artery occlusion and significant CAD in patients with NSTEMI ECS. Thank you for your attention.